Good evening and welcome to this course of Aula Dentaid. Aula Dentaid, as you know, represents the commitment of Dentaid to oral health training. In this course, we want to focus on the importance of the relationship between oral health and general health. Oral care not only maintains oral health, but it also helps to improve general health, as we will see in the different sessions. The aim of this course is to help to reduce cardiovascular risk of our patients by improving their oral health. With this objective, and in collaboration with the Spanish Society of Periodontology, SEPA, we have organized this Aula Dentaid course, Periodontal Pathologies and Cardiovascular Diseases. It's a course that it is divided into 3 sessions, in which we will have different experts as speakers, periodontists and cardiologists of the highest reputation. I want to take this opportunity to thank in my name and on behalf of Dentaid for the participation of all speakers, and thanks again to the audience. Special thanks to Dr. Miguel Carasol for his time and dedication as the scientific coordinator of this course. Dr. Carasol, thank you very much for being here.
Thank you very much, Ernesto. So, dear friends, welcome to the first edition of this course on the relationship of periodontal and cardiovascular diseases in the dental office. Thank you very much for being with us, whatever country you are in. Of course, thanks to the Spanish Society of Periodontology and especially to Dentaid for their serious and enthusiastic sponsorship of this initiative, which has already been very successful in its Spanish edition. Also, a special thanks to the speakers of the 3 webinars that compose the course. They are great experts in their fields and will transmit us their knowledge in a very practical way. In this first session, we will put into practice the relationship between dentists and cardiologists, in addition to presenting a protocol developed by SEPA for the assessment of metabolic and cardiovascular risk in the dental office. For this purpose, we are very honored to have 2 sisters. Dr. Maria Molina is a specialist in cardiology, works in the cardiology area of the Severo Ochoa Hospital in Madrid, where also she coordinates the cardiac rehabilitation unit. On the other side, Ana Molina has a degree in dentistry, a master in dental science, a master in periodontics, both of them from the Complutense University of Madrid, and she has the European Board on Periodontics from the European Federation of Periodontology. So they are going to talk to us about how cardiologists and periodontists can relate to periodontal and cardiovascular risks. Thank you very much, doctoras, and please go ahead.
Thank you. Thank you so much, Miguel, for your very kind introduction. And good evening to everybody that is online with us today. We are very honored to start this course with this first webinar, which, as Miguel just said, is going to be very practical, and we're going to get into the material very soon. So today, what we want to share with you is how we manage cardiovascular and periodontal risk all together, dentists and cardiologists, how we can work together to help our patients improve both their oral and their general health. And in the following webinars, you will enjoy the participation of some of our colleagues that will go in deep into all the data that I saw you in this screen, in this slide, but I will just give you a hint of some data on the association and relationship between periodontitis and cardiovascular diseases. We are dealing with very prevalent diseases in this case. Periodontitis affects 0.5% of the population in the world. It's the 6th most prevalent disease in humans. And in fact, the more advanced forms of disease, what we call nowadays stages 3 and 4, affect 1 out of 10 of our adult patients. So it's very prevalent in the general population and in the population in the dental clinic. On its hand, cardiovascular diseases are also very prevalent entities. They cause 30% of the mortality around the globe, and is the first cause of death when we achieve 60 years or older. Unfortunately, 80% of these deaths are preventable, so we have a lot to do in that sense. If we take a look at the pathogenesis of both diseases, there is a link because as you may know, periodontitis is an inflammatory disease which is triggered by bacteria, by a microbial dysbiosis in the mouth. But this inflammation can lead to a systemic inflammation elevation that can help the pathogenesis of also of cardiovascular diseases by means of the atherosclerosis process, which is behind the occurrence of these entities. They also have some other things in common, such as risk factors, very important. Smoking and diabetes mellitus are both risk factors for periodontitis and cardiovascular diseases, and they are shared between them. And we have also demonstrated that beside the existence of these risk factors, there is a positive and independent association among periodontitis and cardiovascular diseases. In fact, nowadays, we can say that periodontitis is a risk indicator for cardiovascular diseases. It increases the risk of developing these entities and also of dying because of these entities. Fortunately, we have also demonstrated that there are benefits in the treatment of periodontitis in terms of cardiovascular disease, and we can reduce systemic inflammation and we can improve also the cardiovascular function of our patients. So definitely, we are dealing with two prevalent diseases with lots of implications and with a more than demonstrated association between them. So this is the reason why both periodontists and cardiologists started to work together already a few years ago. But very recently, back in 2019, we celebrated in Madrid this workshop, which was held, as I said, in Spain, and was performed jointly by the EFP, by the European Federation of Periodontology, and the World Heart Federation. They joined together, cardiologists and periodontists, and evaluated all the evidence we have in the association between these both diseases and the benefits of its treatment. And as a result of this workshop, there was published a consensus report that gathers all the information, the more actual information that we have on this topic, and also 3 documents that I think are very useful and very interesting for the public and for the professionals. And we're gonna go through them very quickly today. We want you to know a little bit of these recommendations, which are available online at the web of the European Federation of Periodontology, and they are addressed to 3 groups of people. On one hand, the medical healthcare professionals and pharmacists. On the other hand, the dental professionals, and last but not least, patients and the general public. So with no further delay, we're going to start with the first set of recommendations, which are addressed for the medical professionals, and no one better than Maria to show us these recommendations. So Maria, when you want, let us know what recommendations do we have for the cardiologists regarding the association between periodontitis and cardiovascular diseases.
As medical professionals. As medical professionals, we should explain carefully and in detail to our patients the negative impact that periodontitis could have on their global health, especially the increased risk of suffering a cardiovascular event, which is even higher if they already suffer some illness as diabetes. As well as we as routinely in our medical consultation, if the patient keeps smoking or if they are doing some kind of exercise or physical activity, we also should ask about their oral health, looking for signs and symptoms of periodontitis that are not difficult to identify by the patient: red or swollen gums, bleeding, spacings between teeth, teeth migrations, and all those other signs that you all know much better than me, of course. We can even go one step further and use some kind of oral health questionnaire that can help our patient and ourselves to identify if there could be any significant problem related to their periodontal health. This test that I showed you has been developed by CEPA and is easy to quick to fill in a regular medical visit. If the subject obtained a result over 24 points, it will suggest that the patient has a high risk for suffering periodontitis, and we must recommend him to visit his dentist as soon as possible. Of course, when we recommend our patient to visit his dentist, we have to explain him the benefit of this intervention, and even more that this intervention is completely safe for him. Moreover, if they already suffer any cardiovascular disease, if they are already under periodontal treatment, we should try to find out if the appropriate treatment is being provided. Medical professionals should also liaise with dental surgeons before any oral intervention, trying to avoid bleeding or ischemic or thrombosis complication. We must explain very carefully in our medical reports which kind of medication the patient is taking and for how long we want him to keep taking it. If fortunately our patient doesn't suffer periodontitis, we should advise him about the significance of carrying out at least one annual checkup with his dentist. We have to recognize the huge effort that CEPA has been doing in the last years to improve the periodontal and general health of many, many patients and to spread the knowledge of the systemic implication of periodontal health among other medical specialties. For this purpose, CEPA has established different work groups with many medical societies, such as the Spanish Society of Diabetes, the Spanish Society of Cardiology, the Spanish Society of Gynecology, and the Spanish Society of Primary Care. In a similar way, the European Federation of Periodontology has developed different initiatives to disseminate the importance of periodontal health in the general population. For example, the Gum Health Day, as you can see, was created to raise public awareness of the importance of the periodontal disease and their relationship with another illness as diabetes, cardiovascular disease, and pregnancy complication. As this consensus provides very useful information for medical professionals, also provides useful and very easy information for the patients. Educating them in the early recognition of signs and symptoms of gum disease, explaining the links between cardiovascular and periodontal diseases, and advising patients to keep their gums healthy by means of brushing their teeth at least twice a day for 2 minutes, cleaning between teeth, using interdental devices, and using a specific toothpaste and mouth rinses if it needs, is very useful. Patients should know that an untreated gum disease can lead to tooth loss and may aggravate cardiovascular disease. For this reason, and knowing that it is also a chronic condition, patients have to understand that gum health requires lifelong attention, even if they don't notice any sign, and especially if they smoke or already suffer from any cardiovascular disease. Cardiovascular and periodontal disease share multiple risk factors in common: smoking, unhealthy diet, lack of exercise, obesity, hypertension, stress, and patients should be informed that any change in their cardiovascular status or any change in their treatment must be communicated to their dentist, with a special interest in the antiplatelet or in the anticoagulant therapies. CEPA has developed a digital platform called Cuida tus encías, Take Care of Your Gums, aimed to promote gum health among general public, with highly interesting information for the patient about their oral health. There they can access to all the recommendations that I have mentioned before. Also, they have access to very updated information about treatments, benefits, and progress in the knowledge of the periodontal disease. And the next group of recommendation is aimed to the oral health care team, and Anna is going to explain it to us.
Which has been especially developed for us, for the dental healthcare team. And first of all, they encourage us to fulfill a very comprehensive medical history of our patients when they first come to the visit, and obviously to update it at every single maintenance visit. And in this medical history, we have to look for cardiovascular risk factors. We have to look for them, try to identify them, and if the patient has not been diagnosed of any of these diseases, inform them whenever these risk factors are present that they should check with their medical specialist whether they are at a higher risk or not of developing this disease. So we have to screen the presence of these risk factors in the medical history. We obviously, as we do very frequently, have to encourage our patients to have an adequate and an optimal oral hygiene, brushing at least twice a day, because this has proven to reduce also the risk of developing acute cardiovascular disease events. And something which is really important, and one of the key messages that we would like to give you today, is that we, as dental professionals, we have to know and to be aware that the treatment of periodontitis is perfectly safe in these patients. We have not to be afraid of providing periodontal treatment in these patients, because we are not going to increase the chances of having an event just by performing scaling and root planning or a periodontal surgery or a tooth extraction. Moreover, we are also many times afraid of having hemorrhagic bleeding problems in the clinic, and we have to know that bleeding risk is usually very low in the procedures that we carry out on a daily basis. If the patient is undergoing any antiplatelet or anticoagulant therapy, in most cases we will not need to interrupt this therapy, and we can also use local hemostatic measurements to control bleeding if necessary. So we can treat them very easily and very safely in the clinic. In fact, this treatment, as we have mentioned before, has proven to have benefits in terms of both oral health, obviously, and cardiovascular health. So we have to provide them to the patient if it's needed. So if we try to summarize which kind of patients we can find in the clinic, there are three types of patients we can deal with. On one hand, patients with periodontitis, but with no further systemic diseases. In this case, we have to inform them that only the fact that they have periodontitis in their mouth is going to increase the risk of suffering cardiovascular diseases. We also have to promote the control of these cardiovascular disease risk factors in the daily life, especially all those lifestyle factors that can be controlled from the standpoint of the patient. And we have to obviously provide him with adequate oral hygiene instructions, brushing twice, interdental cleaning. In some cases, we can implement also use of coadjuvants like a chemical plaque control. And if our patient has cardiovascular diseases, in this case, what we have to do is to screen for the periodontal status of the patients. We have to perform a very comprehensive and thorough oral examination that will include a full mouth periodontal evaluation and obviously bleeding scores to detect inflammation in the gums. And after this evaluation, we will be able to diagnose if the patient has periodontitis or not. If he doesn't have any periodontitis, if he is healthy from the periodontal standpoint, we will implement a preventive care regime and we will monitor the patient at least once per year. But if he is diagnosed with periodontitis and we confirm that besides cardiovascular disease, he has a periodontal disease, we will treat him. And as soon as the patient cardiovascular status allows, we will not delay treatment because of his cardiovascular disease. In fact, one of the recommendations that has been highlighted in this consensus is that if we are dealing with a stage 4 periodontitis in which the function of the patient has been affected by the loss of teeth, we have to promote the dental rehabilitation of that patient because it will give him function and an adequate masticatory organ so he can have an adequate nutrition, which is very important in this kind of patients. And now we can have a patient that has both periodontitis and cardiovascular disease. In this case, we have to implement even more strict regimes for prevention, therapy, and maintenance of their oral health status. Irrespectively of the level of cardiovascular disease and the medication that he has taken, we can provide non-surgical periodontal therapy very safely. So that's something that we want to really stress and highlight today. Non-surgical periodontal therapy is perfectly safe in a cardiovascular disease patient, no matter how long has been since he has had an event, for example. We also have to be updated in terms of the prevention of endocarditis by means of antibiotic prophylaxis, because nowadays current guidelines have limited very much the indications of the use of antibiotics to prevent this kind of infections. So we will only provide antibiotics in the cases that the guidelines recommend. And in this case, you will have in the following seminars and webinars specific recommendations, so be attentive. If we have to do further treatment besides non-surgical period treatment, we can do it and it can be provided similarly that we do in patients that have no cardiovascular diseases. But if we are dealing with a cardiovascular patients, we have to pay special attention to two aspects. First, the blood pressure, just immediately before the intervention, and if the patient has blood pressure which is higher than 180/100, we should postpone the intervention to another day. That's a very strong recommendation that we have made in this consensus. And we have also to assess the bleeding risk of the intervention we are providing. And this is something that comes into our responsibility. It's the dentist who has to assess the bleeding risk of the intervention. And if it's high, he should speak with the medical professional to change or not the antiplatelet medication. We will not take the decision whether to change the medication, the antiplatelet or anticoagulant medication, but we will assess the risk of bleeding of the intervention and we communicate with our medical colleague. Obviously, if we are going to perform a non-critical intervention, which is not necessary, but requires the discontinuation of the antiplatelet therapy, and if this intervention is not needed, we will postpone it and do it 1 year after the cardiovascular, even when the patient is no longer under dual antiplatelet therapy. So once we have reviewed all these recommendations addressed for the cardiologists, for the patients, and obviously for the periodontist, I ask myself, what do I expect from the cardiologist when he is treating a patient with cardiovascular disease? Well, what I will ask a cardiologist to do in the medical setting is to try to identify and screen if this patient who has a cardiovascular disease also has periodontal disease or is at higher risk of developing this disease. And if so, it's confirmed to refer the patient to its dentist to receive the appropriate treatment. Obviously, I want also the cardiologist to communicate to the patient that the treatment is safe. So once the patient arrives to my consultation, he is relaxed and he's not afraid of having an event just because we are doing, for example, a dental extraction. And obviously, they have to educate as well the patients on the medication they are taking, the consequences this medication have, and whether or not they have to take antibiotic prophylaxis for the treatment of this infective endocarditis. So in this sense, to see how we relate one to each other and how we communicate, cardiologists and dentists, Maria and myself would like to share with you one clinical case to show somehow the way we treat this on a daily basis. So Maria, whenever you want, is yours.
Yes, I would like to show you one of the cases of my patients. I would like to introduce you one of this patient. His name is Luis. He's a 63 years old man. He's married and works as a car salesman. He doesn't refer any allergy. He's a current smoker of more than 20 cigarettes per day, so he's a heavy smoker, and suffers hypertension treated with only one drug, enalapril 20 milligrams per day, and he also suffers diabetes treated with metformin and with regular control, as you can see, with a value of glycosylated hemoglobin of 8.6%. There is no other medical background of our interest, only one minor surgery. Luis suffered a heart attack back in August 2019. As you can see in this angiography, one of the main arteries of the heart, the left anterior descending artery, is seriously affected with a severe stenosis. You can see the stenosis pointed with a red arrow. I hope you can see it. The cardiologist performed an angioplasty and a stent was placed where the stenosis was located. Luis' heart didn't suffer any irreversible damage and the ejection fraction of the ventricle was preserved. So Luis was so lucky at this point. You can see in this image how the flow of the artery is restored properly now that the stent has been placed where the stenosis was in the previous video. At hospital discharge, Luis must take all this medication, double antiplatelet treatment with acetyl salicylic acid, anticoagulant, and other medications to control the glycemic levels, the cholesterol, and the blood pressure. We are also very worried about the impact that this heart attack can have in Luis' life. We want to give him back his place in the world, in his job, in his family, and also in the society. Many times when a person suffers an acute myocardial infarction, our own social environment turns the patient into a really, really sick person, and making her, if she's a woman, believe they are no longer able to take care of their family, their job anymore. So we invest a lot of time and resources in reconditioning these patients, restoring their functionality, improving their physical and mental health, and putting them back into the place they belong to in the society. Of course, we also have to explain the patients the reasons that lead them to suffer a heart attack, which are mostly the risk factors of cardiovascular disease, and which change they have to implement in their life in order to avoid a new event in the future. As you can imagine, this work needs many different professionals. In the psychosocial area, we collaborate with psychologists and social workers also. In the cardiology area, we improve the treatment to ensure the optimum control of the risk factors. We also make a prognosis assessment of every patient and look for other pathologies related with cardiovascular disease, like, for example, sleep apnea, anxiety, depression, stress, sexual dysfunction, periodontal disease, of course. Our nurses educate the patients in healthy habits, which includes a healthy diet and regular physical activity. And we give them different options to achieve smoking cessations. In the first visit to my consultation at the cardiac rehabilitation unit, Luis present high blood pressure values. And for this reason, I decide to add a new drug to his prescription. It was amlodipine. His glycemic control was much better, and his cholesterol level was good, but not optimum. So I also add another drug to his treatment. It was etrol in this case. He was still smoking, less cigarettes, it is true, but he was still smoking just 1 month after suffering a heart attack. So we sent him to a smoking cessation group therapy and recommend him to try to keep with a new pharmacological therapy with varenicline. Looking for new pathologies, we found that Luis had a normal sleep pattern, a high level of smoking dependency, no signs of significant anxiety or depression in this case, and he presented also signs of moderate sexual dysfunction. So we referred him to the urologist especially for its treatment. Luis filled in the test that we give to all the patients in the unit looking for signs or symptoms of periodontal disease, which is a test that I have already shown you before, developed for the Spanish Society of Periodontology, for SEPA, and we found that he had a high risk of developing or being already suffering from periodontal disease. In these cases, we strongly recommend our patients to visit the dentist, and that was what we did with Luis, of course. At this point, I want to treat my patient's periodontitis. I know he has suffered a heart attack just 1 month ago. I know he's taking dual antiplatelet treatment, but I also know that his inflammation's level is now really, really high, and I want it to decrease. So what do I expect from the periodontist, from his dentist? I want his dentist to take an active role in the screening for new risk factors, especially diabetes and smoking. I think that the dentist should ask about these aspects to the patients and try to find clinical predictors of these diseases. For example, the Find Risk questionnaire is a very easy questionnaire, which allows us to identify those patients in high risk of suffering or developing diabetes. And of course, I want the dentist to treat my patient's periodontal disease and to reduce his systemic inflammation, which will translate into a general improvement of his systemic health. So, in this point, Anna, please let me know what can you do with my patient.
Fulfill the requirements that we saw before. She has a screen for the periodontal status of the patient, and she has referred him to the dentist because she has found that Luis had a higher risk of developing or suffering periodontitis. So now it's our turn as dental professionals to accomplish the requirements of the cardiologist. So when the patient arrives to the clinic, the first thing we do, obviously, is an oral exam, a complete oral exam. We will do a full periodontal examination, including plaque indexes, bleeding indexes, periodontal probing, mobility, furcation affectation, etc. And we will complement this periodontal examination with a radiographic exam, with an OPE, and maybe with a set of periapical x-rays. And whenever it's available, we can also complement this with some microbial testing. So this is the intraoral aspect of Luis when he gets to the dental clinic a few months after the myocardial infarction. As you can see, he has quite a lot of inflammation. The gums are very swollen, and they have also enlargements in both the anterior and posterior areas, as you can see in the papillas. In some cases, we have not only pocketing, but pseudo-pocketing, because the gingiva is above the cementum enamel junction. This is the X-ray where you can appreciate that he has generalized horizontal bone loss pattern. You can see the amount of bone loss more in detail in this set of periapical X-rays, and there are some teeth that have even less than 50% of a remnant bone. So definitely quite an advanced periodontitis. If we take a look at the periodontal examination, we are confirming what we saw in the clinical intraoral exam and in the X-rays. There are pockets of up to 11-13 millimeters of depth. He has generalized bleeding, plaque index of 100%, and even suppuration in some teeth. So once we have gathered all this data, we are more than ready to perform our periodontal diagnosis, and we will do it following the last guidelines of the European Federation of Periodontology and American Academy of Periodontology, according to the 2017 World Workshop for the Classification of Periodontal and Peri-implant Diseases. And in this case, I think that you will agree with me that we are dealing with a periodontitis stage 4, because he has more than 5 millimeters of interdental clinical attachment loss, and he has lost more than 5 teeth. So in terms of progression, even though our patient has a progression rate of a grade B according to the bone loss with regards to the age, we do not have to forget that our patient is a diabetic patient and that his glycated hemoglobin is above 7. So that will lead us to a higher grade of progression, a grade C. But not only this, we have to take into account that our patient also presents a gingival disease, which is a drug-influenced gingival enlargement, which has been caused by the calcium channel blocking drug that he's taking, in this specific case, the amlodipine. So we will have to deal with a periodontitis, stage 4 grade C, a very advanced case of periodontitis, and at the same time, a drug-induced gingival enlargement. So what can we do for this patient? How do we perform our treatment plan? And again, we go to the evidence that we have from the last workshop of the EFP that has provided us with a clinical practice guideline, very recently published, but available for all of you at Journal of Clinical Periodontology and at the web page of the EFP. And following this guideline, we have to identify and to perform all these steps in the order I show you in the slide. First of all, we will inform our patient about the disease he is suffering and the causes that led him to suffer periodontitis. And before going any step further, we have to do systemic and risk factors control. And there's a lot we have to do in this patient regarding this second step of the therapy. We will prepare a very short and brief summary of the patient conditioning factors. He had high blood pressure, which is poorly controlled so far. He also had drug-induced gingival enlargement, as we have diagnosed. He is under dual antiplatelet therapy. He's still a current smoker, and he has diabetes mellitus. And all these conditioning factors will affect our treatment plan. On the first place, the fact that he has high blood pressure will have an influence in the periodontal therapy and also in the management of the anxiety that we will do in the dental office, because we don't want to have a high hypertension crisis in the dental office. So we know that the cardiologist is already working on trying to control this hypertension by means of adding this second drug, the amlodipine, that he added in the 1 month follow-up visit after the infarction. And we also have to recommend the patient to control regularly his blood pressure at home. So if he's going to come to the dental office and the days before the appointment, his blood pressure is over 135/80, his cardiologist is going to recommend him to add another dose of amlodipine daily. Also, if the patient is very nervous and is very afraid of the treatment and has lots of anxiety, we can recommend him to take a benzodiazepine even the night before and the morning before the appointment, so he comes much more relaxed to the dental visit and he does not suffer a crisis in the office. Okay, and obviously before any periodontal periodontal or dental procedure at all, we will check for the blood pressure of the patient in office. If the patient has blood pressure above 180 and 110 milligrams of mercury in the office, we will cancel the treatment procedure that was planned and we will postpone it until the patient has normal blood pressure levels. But we have said that he has high blood pressure, that we are trying to control it with amlodipine, but this amlodipine is also causing a problem, which is this drug-induced gingival enlargement. And this drug-induced gingival enlargement is going to compromise the result of my therapy, because no matter how good periodontist I could be, that I will not be able to control this pseudopocketing and this huge hypertrophy he has in the gums if I do not eliminate this drug. So what I do is I speak with the cardiologist and I send him a referral note, and I tell him that the patient is being treated periodontitis, but he also has drug-induced enlargement due to this amlodipine. So I asked the cardiologist if he or she could consider changing this medication by another drug of a different family of drugs that does the same effect, but without the side effect of the gingival enlargement. And you will see that in most cases, cardiologists are very prone to help us, and they will modify the medication. The cardiologist, in this case, Maria, she stopped the treatment with amlodipine and add instead valsartan 160 milligrams per day to help the patient control the blood pressure, but eliminating this side effect. We also had the conditioning factor of the dual antiplatelet therapy that can lead us to some bleeding troubles in the clinic. And as you will see in following webinars, in most cases, it is not necessary at all to stop this treatment in the patient to perform non-surgical periodontal treatment. Let's do not remember that the patient has had a myocardial infarction less than 6 months ago, so the risk of thrombosis is very, very high if the antiplatelet medication is discontinued. So we do not have to change it. We can perfectly perform non-surgical periodontal therapy and control bleeding by means of hemostasis measurements, such as the use of tranexamic acid. We can do pressure, we can do an adequate suturing, we can use aminocaproic acid as well. We have plenty of options, collagen sponges and collagen there is also this foam that you can apply to the patient. We have plenty of options that we can apply in a local manner in our patients to control bleeding. And obviously we can do it in short visits, separated in times. We do not have to do full mouth scaling and root planning in one session. We can do it by quadrants, so that will reduce also the bleeding in these patients. So many ways to control this problem without having to change patients' medication. We also have two very much important risk factors to control, which are the smoking status of the patient and the diabetes mellitus. Both risk factors, as we have mentioned at the beginning of the presentations, are common risk factors for both cardiovascular diseases and periodontitis. And we are working together with the cardiologist to control them. We know that the cardiologist has referred the patient to a smoking cessation work group, and she has also recommend the patient to use varenicline to reduce his habit. He is also trying to control the glycated hemoglobin levels by means of exercise, diet, and weight monitoring, as Maria has recommended him. And what can we do as a dentist? Well, we have to fulfill or we have to give our patient more support regarding this message. We have to reinforce the cardiologist's message and to inform the patient that smoking cessation is not going to be a benefit only from the cardiovascular standpoint, but also from the periodontal health status. And we have also to inform the patient that if he gets to an adequate level of diabetes mellitus control, the results of the therapy are going to be better, and he's going to reduce the risk of developing further progression of his periodontitis. So it's a bidirectional relationship that it has. So once we have controlled all these systemic conditioning factors, we can go ahead and follow with the following steps of the therapy. We are not going through them very much in deep, but we are going to show you how the patient evolve and how he progressed after therapy. And this is the change that he has in his periodontal status after scaling and root planning and the modification of the drug therapy, the amlodipine. 2 months later, we have a very marked reduction in the inflammation, obviously lots of recession, but the gums look much nicer. There is still pocketing, so we perform a second phase of surgical periodontal therapy, and this is the status of the patient after the resective surgery and 1 year of periodontal maintenance care. So we have been able to control his oral inflammation, and we know by several studies that this will also have a translation into his systemic status and his systemic inflammation that is going to be for sure decreased. And this is the state from the periodontal status, but also from the cardiovascular standpoint, there has been improvement. This is the status of the patient at the medical consultation with Maria 1 year after the acute myocardial infarction. He's asymptomatic from the cardiovascular standpoint. He hasn't had any further events. And regarding his clinical situation, the blood pressure has been controlled. Now it's quite nicely with 125/68 levels. We have also been able to further reduce the glycated hemoglobin up to 7.3. It's still not perfect, but we are quite pleased with it. We have reduced the LDL cholesterol up to 53 levels. Unfortunately, the patient has stopped smoking 6 months ago, so we are both very pleased, the cardiologist and myself. He's still doing exercise and controlling his diet. So 1 year after the cardiovascular event, the cardiologist is going to stop the treatment with the Brilique. She's gonna only leave the patients with the acetyl salicylic acid, but that will stay with the patients forever and ever. So he will only have one antiplatelet drug. So we have been quite successful from my point of view in terms of periodontal and cardiovascular treatment. And just to conclude this, we want to highlight that we have a very important role because we are both dealing with very prevalent pathologies that can affect the quality of life of our patients from many different aspects. And they also have very important socioeconomic implications. We have decreased, for example, the mortality of cardiovascular diseases, but the morbidities associated are still very high. So there's a lot we can do from the prevention standpoint. Also, we have to encourage the knowledge that periodontal treatment has a positive effect from the oral aspect, but also from the systemic standpoint of the patients. We will reduce the systemic inflammation and we will improve also some surrogate cardiovascular disease outcomes that will translate into a benefit in the cardiovascular health of these patients. So to get all these results, all these nice results, we have to collaborate and to work together, both physicians and dentists. We have to go hand in hand trying to improve the general health of our patients. And as you can see, there's a lot we can do. So with this, I would like to thank you in both myself and Maria's name for your attention. And I will give back a word to Professor Miguel Carasol. So Miguel, whenever you want.
Okay, Ana, Maria, and Ana, thank you so much for your very brilliant and practical exposition of what the increasingly frequent collaboration between cardiologists and dentists is so important. I think it's essential because of the enormous benefit for patients, as we have seen in this scientific, practical, and nice conference. Thank you very much. And now, the second part. Dr. Ana Molina is going to present us a very simple protocol to assess in the dental office metabolic risks, in this case applied to the cardiovascular field. This protocol was designed by the Spanish Society of Periodontology, is very simple, is applicable in any dental practice, as Dr. Ana Molina will now explain to us. So, if you are ready, come on with this. Thank you so much, Ana.
Thank you, Miguel, again, and thank you so much for the opportunity of sharing this protocol with our audience, because I have to give you all the credit. This has been developed by you. You are the brain behind this protocol and this idea, so I will just be a mean to show you this protocol and to present it to you, but Miguel is definitely who has to receive all the credit for this. So what we are going to show you right now is a protocol that has been developed by Miguel together with CEPA to try to detect and screen metabolic and cardiovascular risk factors in the dental office from a very easy point of view. Why this protocol has been developed? Well, actually, the dental office is a great point for screening systemic diseases. And why is that? Because patients come very often. They used not to come that often in the past, but nowadays we are improving the attendance of our patients. And in fact, there are some studies that say that more than 60% of the American adults go to the dentist every year. So that's quite a huge success if we take back a look at some years ago where patients only went when they have pain or they had infection or something. So nowadays, patients are much more used to go and visit the dentist on a regular basis for dental checkups. So we have lots of opportunities to see many patients and to see them on a regular basis. In fact, we get to see them even more often than their physicians many times, because if the patient is healthy, he will not go to his medical specialist, but he will go for dental checkups every 6 months or every 12 months, depending on its needs. And in fact, this is important because many of our patients, they think that they are healthy, they think that they have no systemic problems, but they might be developing them, they might be at early stages of their disease, or they might have some risk factors that, if controlled on an early basis, can prevent the occurrence of these advanced forms of disease. So we have a huge opportunity to screen for the occurrence of these non-communicable diseases in the dental office. And they are very prevalent. We have been speaking only about cardiovascular diseases, but also diabetes, chronic respiratory diseases, cancer. They account for almost 7 out of 10 deaths worldwide every year. That's a lot. And most of these diseases, as I said before, are preventable or are easily treated if they are diagnosed at an early stage. So what can we do in the office? First, we cannot do diagnosis of these entities. We can do screening. We can detect systemic risk factors and we can detect early signs or symptoms of these diseases. But always the diagnosis, the final diagnosis, has to be done by a medical specialist. We can diagnose, or we can screen, better said, the early status of diabetes, which is prediabetes or diabetes mellitus in the office. We can also look for cardiovascular risk factors and to perform also some morphometric tests that will guide us on the diagnosis or screening of these entities. And why have we put our focus on the screening of both diabetes and cardiovascular diseases? Well, they are both very prevalent, and as we have been speaking before, they have a quite important and demonstrated association with periodontitis. In fact, diabetes is probably the systemic disease with the highest and most important association with periodontitis, and this association is bidirectional. It goes both ways. Periodontitis can increase the risk of developing diabetes mellitus, and also when periodontitis is not adequately controlled, the patients will have problems controlling their glycemic levels. And on the other hand, when a patient has diabetes, has a higher risk of developing periodontitis and has also a higher risk of developing more advanced forms and more rapidly progressive forms of periodontitis. So both entities interact with each other. And to detect the risk of diabetes is quite simple in the office, as we will see in the following slides. This data is from a study that we have performed in the Spanish population, which is quite interesting. In total, we have 12% of adults that suffer from diabetes in Spain, and 4% of them do not know that they have diabetes. It's not diagnosed. And sometimes in the very earliest stages, it's very easy to treat. Sometimes it's just a change in lifestyle, in diet, in exercise. Those patients will not need drugs and will not develop further stages of advanced forms of diabetes. But still, out of these 12% of patients with diabetes, 4% do not know that they are suffering this disease. So definitely we have plenty of people to screen and to detect these possible signs of diabetes, to refer them to the dentist to confirm the diagnosis. The second entity that we want to screen is cardiovascular diseases. As we have mentioned before, they are very prevalent and they have very lethal consequences. More than 30% of the global deaths in the world are caused by cardiovascular diseases, and 80% of these deaths are preventable if we treat them properly and at early stage. In this case, the association is not bidirectional, it goes only one way. Periodontitis increases the risk of cardiovascular diseases, but fortunately for us, cardiovascular diseases does not increase the risk of periodontitis, but they share a lot of risk factors in common, such as smoking and the previously mentioned diabetes. So there is a strong association among them that we have to treat jointly. In fact, as we have mentioned, 30% of global deaths occur due to cardiovascular disease. In Spain, the percentage is a little bit lower. We have been decreasing mortality in the last few decades. However, patients survive, they live longer, but with lots of morbidity. So still there's a lot to do in terms of prevention. In 2017, for example, there were 120,000 strokes in Spain, and 20% of those patients died. 20% died, but above all, among all the 80 that survived, 40% had very severe disabilities, with the impact that this has in both the health sanitary aspect and also the economic one. And probably the most common cause of death in Spain was coronary ischemia, with 7% of the deaths that occurred in 2017 in Spain. So definitely quite a lethal disease. Another entity that has to be screened when we are looking for cardiovascular risk factors is arterial hypertension. It's extremely prevalent. 4 out of 10 subjects will have it, and it's even more prevalent in males than in females. And in most cases, in almost 38% of the cases, it goes also undiagnosed. The patients do not receive treatment, they do not implement any measurements to control this hypertension, and that poses them on a very high risk of developing both diabetes and further cardiovascular entities. So hypertension is also another entity that we have to screen very frequently in our patients in the dental office. And last, one entity which is probably less known or less common is atrial fibrillation. It does not affect as many patients. It has a prevalence of less than 5%, but when a patient suffers from atrial fibrillation and his heart is not working properly and the contraction rhythm is not adequate, he will be in further risk of a stroke. Actually, his risk of suffering a stroke is 5 times higher than a patient that is not suffering from atrial fibrillation. In fact, recent guidelines of the European Association Federation of Cardiology, they recommend to screen for atrial fibrillation in patients over 65 years of age in order to detect this abnormal rhythm of the heart and to prevent this risk of a stroke that is so increased in patients with atrial fibrillation. So we have lots of things to screen that are quite prevalent and that have very high impact in the health of our patients. How can we do it in the dental office? Well, first we have to ask ourselves which patients are subsidiary of this screening, because not all patients will need to be screened for this entity. We have not to do it in every patient that comes from the street to our door. We have to screen for diabetes mellitus in patients that are over 45 years old, and it is recommended to repeat this screening every 3 years to do it on a regular basis. But if the patient has any risk factors such as overweight or obesity, or he has a sedentary life, he has a history of diabetes in the family, or it's a woman that had gestational diabetes when she was pregnant, in this case, even though if the patient is younger, we should screen he or she for the diagnosis of diabetes mellitus disorders. In the case of cardiovascular diseases, the evaluation of its risk is recommended in men over 50 years of age, and in women a little bit later, when the risk of cardiovascular gets equal between men and women, which is over 50 years of age or after the menopause, or whenever they have risk factors that have been identified but not diagnosed first. Again, this should not be done once in a lifetime. We should repeat this screening, and it's recommended to do it every 5 years when the patient gets into these ranges of age. So how can we implement it in the clinic? Which steps do we have to take? Our recommendation is next. the first visit of the patient, the first time we see he or she in the clinic, we are going to take some previous steps. We are going to fulfill the medical record, and we are going to look for this cardiovascular diseases history, diabetes, renal insufficiency. Of course, we're going to register all the medication, all the drugs he is taking for the treatment of any diseases. We will also record all neglective habits that the patient has, such as the use of tobacco, alcohol. We will ask the patient if he has an adequate nutrition and if he or she does exercise on a regular basis. And in this first appointment, we will not do the full screening for cardiometabolic risk factors, but we will explain the patient that there is an option to perform some very easy, quick, and non-invasive tests to check for this the existence of these possible diseases. So we will explain them why we are doing this screening and the association that these diseases have with their oral status, how long does it take, and also we can inform them about the price, obviously. So once the patient is informed, in the next visit, we could do it. So we will do it in a second visit where the patient is much more relaxed. He comes, he knows us, and he is going to start the treatment. So what we do? First, we have to measure blood pressure, which is something that we have to do on a regular basis. And we can also check for the radial pulse to look for atrial fibrillation. In fact, there are some devices that measure automatically the blood pressure that also will check for the presence of atrial fibrillation. You don't have to do it yourself if you are not trained, but it's very easy to do. It can be done with a machine. How can we measure properly the presence of hypertension? Well, the patient has to be sitting, obviously. He or she cannot be standing on his feet. The cuff has to be placed on one of its arms at the level of the heart, and the patient have to be rested for at least 5 minutes. We cannot do it right away when the patient comes rushing and running into the office because he's late or she's late. We have to have a relaxed patient that had been resting for at least 5 minutes. We will do a first measurement, and if it's above 140 and 90 milligrams of mercury, we will repeat the measure. If it differs substantially one to the other, we will do a third measurement and we will take the lowest value of them all. Why we take the lowest value? Because many times when the patient has his blood pressure checked, he or she gets nervous and he gets a little bit of anxiety, and especially even more when he is in the dental office. So sometimes we can have a false positive or higher levels because of the anxiety and the stress of the patient. So we'll repeat the measurement when he is much more relaxed to have a reliable level. If the measurement provides us a result which is above 190 milligrams of mercury, we will recommend the patient for a medical evaluation to confirm whether he has or not hypertension. To check for atrial fibrillation, as I mentioned before, is quite easy. We can just check for the radial pulse, but we are not going to measure the pulse, but we are going to look whether it's irregular or regular, whether it follows a regular pattern or it has irregular pattern of pulse. If the rhythm is irregular, we will also recommend the patient to go to his medical specialist to confirm the diagnosis with an electrocardiogram. Regarding the metabolic risk, we also have to measure the body mass index of the patient, which is quite easy, and you have many automatic ways to calculate it online. We can also check for the presence of visceral fat, and we can measure in office the abdominal perimeter, which only will take you a few seconds to assess whether the patient is obese or has overweight or not, or he's in a normal weight in the best of the cases. We also have to check for the presence of risk factors of diabetes, and in this case we have a very simple scale, which is the Fine Risk Scale, which is available online for you. It has developed in Europe, and we have tested here in Spain. In fact, results have been published very recently, and it has been done by our research group at Complutense University by Dr. Eduardo Montero and David Herrera. They have implemented these fine risk questionnaires in 40 dental offices in Spain. It's a very simple questionnaire with very simple questions that the patient answers in just a couple of minutes. And that has led us to very surprising results, because we were able to diagnose 8% of patients with diabetes and prediabetes that was not diagnosed. So 1 out of the 10 patients we saw in those clinics had diabetes or prediabetes that has not been diagnosed, and we were able to diagnose them on an early stage. So it had a huge impact. As I said, this scale is very simple to measure. If it goes above 15 points, the patient is considered to have high or very high risk of suffering diabetes and is referred to his medical specialist to confirm the diagnosis. And as I said, very, very easily applied. We can also complement this fine risk questionnaire with a measurement of glycated hemoglobin in office, just by means of taking a drop of blood from the finger. And we can also measure total cholesterol in office with portable devices. But also the risk of cardiovascular disease. For this, what we use is the score chart. The score chart is a tool which is somehow similar to the Framingham score risk factors that you may know, but this one is much more improved and much more complete. It has been developed for the European population, and it has different charts for the different countries. So you have to look for the chart that applies better to your country. And what the information that this provides us is the 10-year risk of dying due to a fatal cardiovascular event in the population. So this chart, as you can see, has like a gradient of colors. If we are in the stronger green color, we have a very low risk of dying because of cardiovascular diseases event. But if we go up in the chart and we go to the darker red, we have a higher risk. And which outcomes do we use to measure this risk? Well, we apply gender, age, the use of tobacco, systolic blood pressure, and total cholesterol. As you know, they are very easy to measure. Total cholesterol is the one that is a little bit more difficult, but we have those portable devices that I saw you earlier that can be used in the dental office. And we will get a result very high or low risk of this fatal cardiovascular disease event. And once we have placed the patient in one of these categories, we can implement preventive measurements to try to avoid the occurrence of this disease. So it's quite easy to use. It can be also found online, where you just fill the data and it will provide you with the final result of the patient, just with this data on gender, smoking status, age, etc. So what can we do with all this information? Obviously, we're going to provide the results of all these tests to patients, and we will give him a report. And with this report, we want to recommend the patients to go to his physician or his medical specialist to confirm with further testing the diagnosis that we have been screening in the dental office. And we will ask the patient to come back to the clinic to let us know which was the result of this medical examination. We have prepared already some forms that can be provided to the patients with all the data and with explanations on the different pathologies that have been screened, the risk that he has. And we also have to remind that we are not giving a diagnosis to the patient, and this is something that we have to explain to the patient. We are not giving any diagnosis at all, but we are just giving some data that made us suspect that he might suffer from one of these diseases, and that our recommendation is to further confirm the diagnosis. This is some images of the forms that we have prepared together with the Spanish Society of Periodontology, with explanations on both pathologies and also with the results of the different screens that we have performed for the patients to take to his medical specialist. And maybe some of you are thinking, how do patients react when we propose them to undergo this screening of metabolic and cardiac risk factors? Well, there are also studies that have addressed the acceptance of dental patients or patients in the dental setting to the screening of this kind of diseases. And most of them think that it is important that the dentist also takes care of his systemic health and that they perform on a regular basis these screening methods. And in fact, 60% of those patients will be willing to pay to have this screening performed in the dental office. In fact, they think that once his dentist has shown that he has interest in his systemic status, that will provide his dentist with higher competence, with higher knowledge, and they will consider his dentist that he is 90% more professional than other dentists. So definitely is well accepted by our patients. They will appreciate if we do it for them. They will even be willing to pay for it, and they will also appreciate and consider ourselves as better professionals if we only not take care of the oral health status but the systemic status, which definitely is something we have to do, because let's not forget that we are health professionals, not only oral health professionals, and we are treating patients as a whole, not only mouths. So definitely there's a lot we can do in this sense, and a role very important we can play as general health professional providers. So with this, I would like to come back to chat. Thank you. So I don't know if you want to help us with the questions. I don't know if people have any doubts so far.
First of all, thank you for your fantastic conference. We have learned so much about how dentists and cardiologists can interact themselves, and how to manage a cardiovascular patient, also periodontal patients, and the clinical considerations they should take into account to decrease cardiovascular risk of these patients. This is something I have said very quickly, but it is very important. How caring about gums, there is less risk of cardiovascular diseases. I have to say that it was also especially interesting, at least in my opinion, the analysis of this clinical case of that patient from both points of view, from a cardiologist and from a periodontist. Before finishing this session, because we have just run out of time, I have only one question. Do you think we are close to a frequent or a normal relationship between cardiologists and dentists for the management of these patients? What's your opinion? Are we close or not?
I think we're getting closer. We're getting closer, and we are doing many steps forward to this, because nowadays we know much more about the relationship among these diseases, between these diseases, and we have a more fluent communication between the physicians and dentists. Unfortunately, in our setting here in Spain, for example, dentists do not work in the public sanitary system, so that's somehow a shortcoming we have. We cannot be part of the medical team in hospitals or in general clinics. We work in private practices, so that makes cooperation and collaboration a little bit more difficult. But I have to say that whenever I have to get in touch with a doctor, no matter the specialist, if it's an otorrino or if a cardiologist or is a diabetologist, the feedback is always very good. I think they appreciate that we take care of the systemic health of our patients, and they are willing to help us and to know more about periodontal and oral health status. So I think we are getting closer. We're getting closer, and we are doing lots of effort in this way. We are not still in the perfect situation, I think, but we are hopeful that we will get it in the future. I don't know if Maria is the same.
Yes, I agree. I think that a good relationship between us is completely necessary for the good treatment of our patients. But I'm sure that if there were dentists in my hospital working, I would send all my patients. I'm completely sure of that, and I think that my colleagues will do the same. This is not possible. I know that that's not possible now within our system, but we have to find a way to work together. You know, I think that is really, really important. Our societies, the Spanish Society of Cardiology, the Spanish Society of Periodontology, are working together, and this workshop, this recommendation are really, really useful for us. So we are working on it. We have to keep working.
We hope so. So let's do only one more question from this audience. How can we take advantage of local hemostats in emergency situations in patients at high cardiovascular risk?
Yes, I guess that the question goes addressed whenever you have a bleeding emergency or something like that. Well, you have to be very careful with the kind of intervention you are doing. As I said, let's try to divide intervention. If, for example, you have to do several extractions, maybe you can do one extraction per visit, per appointment, and not to do all of them at the same time. Whenever you do, for example, an extraction, you can use several things. You can use collagen hemostatic sponges that you can put inside the socket, and you can do suturing and pressure that will reduce very much the risk of bleeding. You have also to provide the patients with adequate instructions, not to rinse, not to spit in 24 hours. If you have bleeding from the gums because it's not an extraction, because you have done scaling and root canning, for example, there are also some products that you can apply locally. For example, you can find them I don't know if I'm going to find the word in English, like a rinsing solution, okay, like a solution, an hemostatic solution that you can apply to the patient even in a gauze, or just to give it to him to rinse with the hemostatic solution, and that will cut very easily the bleeding. There is also substances that are provided in the gel, which are hemostatics in gel that you can apply locally in those points that are bleeding. You can, of course, apply pressure. You can apply also collagen hemostatics, which are provided like a foam, like Avitene. I don't know if you know it, but it's very useful. It's used in vascular surgery, and it's very instant in terms of cutting bleeding in the oral mucosa. So you have lots of products that are easy to buy and to find in pharmacies even, and that you can apply very easily. In fact, you can also give these solutions to the patient and he can take them home. So if they have a bleeding emergency, like a couple of hours after the appointment, you can instruct them how to use them, how to put this solution in a gauze and apply pressure. And you will deal with most of the emergencies this way. So let's just be very careful to do an adequate diagnosis, try to do a good treatment plan and not to do many things at the same time in those patients, and to use these tools that we have available. They also ask if we can use local anesthetic with adrenaline, if it helps. It helps on the first step, but after the effects of adrenaline goes away, you will have secondary bleeding a few minutes later, maybe a couple of hours later. So don't use them very much, because it will produce a lot of vasoconstriction on a very short time. But then when the base opens again, you will have bleeding. So it will help you with the emergency in a very short time, but in the long term, it's not the most adequate solution. But of course, you can use them for sure.
Okay, so thank you very much for your answers, and of course, thank you very much for your fantastic presentations and conferences. Thank you also to the audience. And in next sessions, we will be learning more about both groups of diseases, the mechanisms that link both diseases, and about the management of these patients. We hope to see you in the next Aula Dentaid session of next week. Thank you very much, Dr. Ana Molina and Dr. Maria Molina, and have a good night. Thank you very much.
Thank you all for connecting. Goodbye. Take care and stay safe.
Good night.
Bye-bye.